you outlined once before your family background. If you would like to do that again.
The family?
Yes.
Well, my father, I suppose we'd call lower middle class, really. But my mother had 8 children. I was the sixth child, and we were not poor, but not rich. Now, he was a public servant, and we all were fairly lucky, I suppose, in that we got lots of scholarships to university anyway. And between us, I think we got 10 scholarships for 8 children, which is not bad, included. Don't you want all this?
Well, this is part of the preliminary chat.
Oh, this doesn't matter.
No.
I oh, I don't know why I'm telling you all this. But, well, where was I up to? Oh, we all 6 of my family went to university. And one became a headmaster of school. He wasn't at the university, but one became a nun. And she could have gone to university. So we all graduated in something like 2. My sister and my brother were doctors, or were doctors, and I am one. And the others did various in engineering and French and so on. Well, now, is that enough for you?
Are we ready? Then I'll pass in. So I'll just give a brief introduction, a very brief introduction. Ready? Yeah. Dr. Irvine, you studied medicine in the 1920s and have worked in poor law hospitals and as a medical officer of health in the north of England and in Exeter before you retired. Can you tell me what changes have you seen in your career in the care and treatment of old people, both in the home and in the hospital, etc.?
Yes. Well, after I graduated, which was in 1927, I did the usual house jobs. I did a couple of house jobs, one in a teaching hospital, one in a general voluntary hospital. And then I went into a poor law hospital as a resident. Now, that was my first contact with old people in a broad sense, because the poor law hospital was really associated with a workhouse. And part of my job was to examine casuals who were coming to the workhouse, and also occasionally, if anybody was in what was called the house, as you know, the workhouses were called the house, and so I met old people in a small way there, but the hospital, which was a large hospital, 500 beds, with dating back, I should think, to the 1840s or thereabouts, because you know in 1834 the guardians were established, the boards of guardians, as opposed to the people who were responsible for the parishes. When the boards of guardians were established to unite parishes, they built a lot of these workhouses. And as I say, it had 500 beds, and a lot of them were very old people. Although it had an acute work, it had a children's block, and one of its wards was quite modern, and the children's block was, in a sense, huts, but they were practical and serviceable. But the old part of the building was all stone, of course. Well, now, just think on, if you have 500 patients, so we had two resident doctors. When I was in the voluntary hospital, I suppose I looked after about 50 patients. When I was in the teaching hospital, I looked after about 25 patients, with other incidental jobs, of course. But just imagine 2 doctors, residents, looking after 500 people. You can't imagine that sort of thing to today. Of course, there were, in any case, doctors today in hospitals have to do a lot more work than they did in those days because there's a lot more known, a lot more electronic work, and a lot more scientific investigation. Well, the thing that presses me now, looking back, is how little we did for some of these old folk. They were in bed from after having a stroke, say a severe stroke. They'd be brought in, looked after, diagnosed, and then virtually no rehabilitation at all. They were simply cared for in bed. And the nurses were very skillful at looking after them in bed, say, very good with the skin, which is a very great trial to nurses, to ensure that they don't get bed sores. So there was a good deal of care in that sense, but rehabilitation there wasn't any. Now in that hospital we hadn't any, with only one consultant who regularly came, a surgeon, came twice a week, once to see patients likely to be needing operation, the other day to do the operations. We had got a technician as our lab man who wasn't qualified, although a very good chap. We also had a radiographer with no consultant for radiology, and of course he knew a lot more about it than I did, and with no physiotherapist, with no occupational therapists, none of these sort of persons. Well, you can imagine the rehabilitation was very slight, virtually nil for these old chronic cases. In those days, the poor law was still in existence, of course, until 1948, and it was run by boards of guardians until 1930. So I was in the hospital when the change took place. The change was to abolish the guardians. That was under the 1929 Local Government Act, and they they transferred the powers of the guardians to the local authorities, the major local authorities, the county councils and county borough councils, and they had to set up they became rather the public assistance authorities. Later on that was called national assistance. But the next change, of course, in the care of the sick was in 1948 when the poor law was abolished altogether. Now the system in those days was that the relieving officers, who were officers of the guardians, could demand the admission of any patient to hospital, usually on the advice of the poor law district medical officers, who were all generally practitioners in this area, and it was originally it had to be on the ground of destitution, but from about 1910 onwards was on a destitution included an inability to get medical care. So it wasn't total destitution, it was relative destitution. But any patient had to be admitted. We had no options. We couldn't say we're not taking him in. We couldn't say you must find another bed. And if we were, as we were at one stage, I remember, in a pneumonia, an influenza epidemic with a lot of pneumonias, we had to put recovering patients on mattresses on the floor because we had to take them in. Whether we had no options, we didn't have any right to refuse a patient. Well, that was the one feature that was good. Another thing, of course, was the tendency for chronically ill persons, especially amongst the elderly, if they were ill, they was to be sent to the hospital, the poor law hospital. Now, as far as the workhouses were concerned, as you know, the poor detested the workhouses, and were very anxious about their fate. They were very nervous of that. Am I going on too long?
No, carry on.
They hated the workhouses. But I can't say much about the workhouse that was associated with our hospital. was quite well run, I think. They're very charming and country sort of matron. The head of the hospital nursing side was called a superintendent nurse. I don't know whether this interests you. I hope it does.
Yes, it is.
But the hospital, I ought to say that the hospital included beds for children, beds for stroke cases and chronic illnesses of various kinds, an acute ward, a surgical ward, and also a mental block. Well, I can't say I knew a lot about medicine, about mental health, mental work, but we had mental patients we had to look after. I looked after the men, broadly speaking, and the other resident, who was a lady doctor, senior to me, looked after the women. But of course we had to share when we were off duty. We got one whole day a week off, and that was one Sunday in two. And we did, in fact, get every alternate afternoon we could please ourselves what we did. That was the arrangement. When I retired from there, when I went from there rather, in 1931, they appointed two doctors instead of one I was. So that was the way that was. Well, now, I wasn't very interested particularly in old people at that stage. I went into public health, and the next thing that interested me in old people was a man coming to my office when I was in medical officer of health, and that would be I became medical officer in 1937.
What was that?
Where was that? That was in Shipley in Yorkshire, in Bradford, near Bradford. And I'm an old man, he wasn't very old, about 60 I should think, white-haired, named Nobby Clark. And as I told you, Nobby was the name that was given to all clerks in that part of the world anyway. Nobby Clark came to me and said, well, isn't it a disgrace that a man in one of the council old people's bungalows was found dead after 2 or 3 days, after 2 or 3 days after his death. And can't you do something about it? He said. Well, I thought around it, and then we decided to ask the council would they agree to appoint a visitor to the old people's bungalows. And it sounds extraordinary today, but you've got to realise the difference in the value of money. But we advertised for a woman to come and visit these bungalows and simply inquire. We appointed for 10 bungalows to inquire whether they were all right, whether the individual was feeling okay and so on. And we paid 10 shillings a week for 1 hour, 6 days a week. And we got a response, and we appointed a woman, and we later on extended this to other little areas of bungalows. We had to increase the wages slightly, but not very much. And these women proved extraordinarily interesting. They liked to do it. They went at 12 o'clock roughly, inquired how the old persons were, one after the other, and they were all received very well. And then they would bring us up at the health department to say, this person needs this sort of help or that sort of help. We undertook to see to it. But what happened was that they would go back in the evening and see how they were. They were freaked out about it. They would bring up the doctors themselves, family doctors, and so on. And it was really quite dramatic. And this old man, Nobby, came back to see me after a year, and he said, the effect on these old people has been electric. That was a very dramatic phrase, and it's remained with me all my life. And that would be about 1943. Well, at that time, people were getting interested in the care of the elderly. I would say up to then, we were far behind America. Not that I didn't like being behind America in any sense, but nevertheless, far behind America, who had developed geriatric medical services. And really, at that point,